So it's my pleasure this afternoon to welcome you to this session. We welcome Jignesh Patel, who's going to talk about the period study, which is learning on managing anticoagulation and menstruation. Jignesh is a clinical academic specialising in anticoagulation and drug therapy and is based between the Department of Hematological Medicine at King's College Hospital and the Institute of the Pharmaceutical Science at King's College London. Jig's research is concerned with the optimal use of anticoagulant therapy in clinical practice and primarily focuses on addressing anticoagulant drug dosing issues where uncertainties exist. A particular focus of Jig's research is anticoagulation therapy as it relates to women's health. So an absolute mind of experience, knowledge, and actually on the grassroots working with patients all the time as well, so able to answer many questions, and he would welcome your questions at the end of his presentation. We have the chat function. We also have the Q&A. The Q&A is easier for us to see your questions sometimes, but please do feel free to post in comments and questions in either of those, and at the end he will do his best to answer as many as possible. But without any more delay, I will pass over to Jig now. Thank you very much.
Thank you, Jo, for the introduction. I'm going to be talking about some work we've done at King's, looking at anticoagulants and what impact it has on women menstruating. It's called the period study. So I'll go through some results and then maybe what we can do to help manage some of the problems that may arise from this. So I'm just oh yeah, there we go. So maybe a good place to start is just to kind of take a step back. And we know that heavy menstrual bleeding affects around a third of women during their menstruating years, irrespective of anticoagulants. And when you look at the historical literature with warfarin, there's not many studies which have been conducted which actually look to quantify how warfarin affects menstrual periods. When I looked back, I could only find 3 studies of note: a Swedish study, an American study, and a UK study from the Royal Free. And collectively, they kind of suggested that around 2/3 of women commencing warfarin or managed on warfarin were experiencing heavy menstrual bleeding. And as a young pharmacist, I never really used to think about this when I was counseling women on warfarin. And when you look at the information booklet that we provide to our anticoagulated patients, particularly on warfarin, you'll see that there is a bullet point on the information provided, but it is a bullet point, and it's at the end of a shopping list of other things that could occur for patients starting any anticoagulant. So it's understandable that if, as a patient, you may not absorb that this may be an issue that will affect you. This problem really came to light for me once DOACs became online, because we started to get women come into our clinic using terms like flooding and having to change sanitary products every hour. And that really focused our mind at King's. And we then conceived the period study to try and understand the scale of the problem and what impact this was having on women. So the period study broadly had 2 aims. It was to report on the extent of bleeding in menstruating women newly commencing anticoagulants and what impact this had on their quality of life in comparison to a control group of women. And then we wanted to dig down deeper into their lived experience. So the women that were menstruating on anticoagulants as well, to really understand what was happening to them. So how did we do this? Well, in brief, we recruited women newly commencing anticoagulants at King's College Hospital. And this was women typically diagnosed for venous thromboembolism, but did have other indications between November 2020 and March 22. We could, in parallel to this, we also recruited a control group of women, and this was through King's College London, who have a volunteer recruitment sort of advert service where we asked menstruating women to take part in our study. What did we ask them to do? Well, we asked them to complete two instruments over 2 consecutive cycles. The first instrument was the menstrual bleeding questionnaire, and this is a questionnaire developed by Mattison from North America. It's a validated questionnaire, and volunteers are asked to complete 20 items which cover 4 specific domains. 1 around bleeding, or 2 around bleeding related to heaviness and irregularity, 1 around pain, and an overall sort of quality of life question. A score is generated between 0 and 100. The higher the score, the more impact the bleeding is having on the volunteers' quality of life. We also ask participants to complete a PBAC. So PBAC standing for Pictorial Bleeding Assessment Chart, which many of you will be familiar with, but these are means to quantify the amount of blood loss which is happening during a menstrual cycle. And so participants had these charts, and then they would record during their cycles the extent of bleeding. And although it's not an exact quantification, it provides a good estimate of how heavy or how light the period may be. These questionnaires were completed online, so each consented woman was provided with a unique link, and they could either complete the questionnaires in real time during their cycles, or we also sent them a paper version which they could complete and then add their data online at the end of their cycles. The differences between the 2 groups were compared, and for the anticoagulated group of women, at the end of their questionnaires, we asked them if they'd be interested in taking part in an in-depth interview, which formed the second objective of the period study. So what did we find? Well, over the period we were recruiting from our clinics, we consented 94 women to take part. So 94 women came forward and volunteered to take part, of which 57 completed 2 consecutive cycles worth of data. As you can see from this slide, the indication for anticoagulation was largely VTE, but we did have a few other indications for anticoagulation as well. And at the time, rivaroxaban was our sort of first line anticoagulant agent for VTE. So just over 40% of women were started on that, closely followed by apixaban. This slide provides a summary of the differences between the anticoagulant and the control group. Just to say, we consented 147 women in the control group, of which 109 completed 2 consecutive cycles worth of data. And I guess maybe before we talk about the differences, maybe the similarities. So the age at which they started to experience periods was similar. There were no differences there, and their length of cycle pre-anticoagulants between the 2 groups was the same as well. There were, however, significant differences in the ethnicity. So in the anticoagulated group, we had more Black women relative to the control group, and in the anticoagulated group, the mean age was much higher, almost 10 years compared to the control group. And we know that women that are older are more likely to suffer with fibroids and adenomyosis, as are Black women as well. So something to bear in mind when we look at the results. So what did we find? Well, this chart is, I guess, our headline result. And what you see here on the x-axis is cycles 1 and 2. And then on the y-axis is a PBAC score. So a PBAC score greater than 100 is thought to equate to, is considered heavy menstrual bleeding. So if I can draw your attention to cycle 1, so the blue boxes, the blue boxes are the control group, and then the red box is the anticoagulated group. And 34% of women in the control group reported p-BAC scores greater than 100, and demonstrates that earlier statement that I made, that around a third of women do experience heavy menstrual bleeding irrespective of anticoagulant therapy. So that 34% in the control group in cycle 1, and that compares to 64% in the anticoagulated group in cycle 1. So 2/3 of women in our anticoagulated group were reporting p-BAC scores greater than 100. And for cycle 2, those numbers are 28% in the control group and 30% in the anticoagulated group. And clearly some women, as you can see by the outliers, some of these dots where the p-BAC scores were around 1,000 or even greater than 1,000, had a torrid time with the anticoagulant. In terms of quality of life, so the Matheson Quality of Life questionnaire was administered, and again we had data for cycles 1 and 2. So what you can see here are the anticoagulated group and the control group data for these 2 cycles, and it's the median with the interquartile range reported in brackets, and you can see a clear difference between the anticoagulated group and the control group consistently when women reported their experiences back. For me, if you'll remember, I said to you that the questionnaire is on a scale of 0 to 100. So these numbers, they don't really bring alive much the experience that women have, apart from showing that there is a difference between the 2 groups. So looking at some of the items within that questionnaire, what you see here is cycles 1 and 2. If I can get your eyes to focus on cycle 1 and the 2 columns for cycle 1, 54% of women in the anticoagulated group reported bleeding soaking through to their outer clothes, compared to around 1/5 of women in the control group. Again, 54% of women got out of bed to change sanitary products at night, compared to just under 1/3 of women in the control group. The end date for the period was not at all predictable for just over 1/3 of women in the anticoagulated group, compared to 5% in the control group. So some clear differences between the 2 groups of women. The interesting finding as well is that I would have expected avoiding social activities to be significantly higher in the anticoagulated group compared to the control group, but actually they're not too far from each other. And my personal theory of that is that the timing of when we did this study probably impacted on that particular finding, because we were recruiting women when we were in and out of lockdowns during COVID. And so although that perhaps helped us because women were at home and probably more likely to complete the questionnaire, I think that finding is probably reflective of that and perhaps would be different if we did the study now. The period study wasn't powered to show any differences between different anticoagulants, but just to give you an idea of, if you did separate out the different findings from the women on the different agents, the rivaroxaban group p-BAC scores were higher than the apixaban groups compared to the warfarin group as well. So there did seem to be some differences, and some agents seem to be much better than other agents in causing this. And sometimes we would have to, of course, change agents because the implicated agent was so problematic. So how does this compare to other data which has been done? Well, there's a very good study presented in London at ISTH in 2022 called the Team VTE study. And this did a similar type of work, and they looked at menstrual bleeding, and they looked over a number of cycles. And again, they reported that quality of life is a significant factor that needs to be considered. They also, in their findings, talk about how a number of women needed to go on for further gynecological investigations. And importantly as well, they felt that some agents are better than others in this setting and report good experience with dabigatran when used in women that are menstruating. So I guess the period study isn't alone, and if anything confirms with the Team VTE study that this is something that we do need to take seriously and manage in our clinics. In terms of the lived experience of women, 16 of the 57 women in the anticoagulated group expressed an interest to do an in-depth interview, of which 15 actually completed the interviews. And I should say not all of them had heavy menstrual bleeding, although most of the women that put themselves forward did experience heavy menstrual bleeding. And to give you a kind of overall headline result, we found that from these interviews, 7 themes emerged, and the themes that emerged reached saturation after 9 interviews, but we wanted to just be sure we weren't missing anything, so we did complete up to 15 interviews. And the themes that emerged was one around how information was framed for women when commencing anticoagulants, what impact the heavy menstrual bleeding had on their mood, the strategies that women developed to manage the heavy menstrual bleeding once they'd started the anticoagulant, the impact the heavy menstrual bleeding had on their social and family life and on their work life, the impact the heavy menstrual bleeding had on their finances. And then for some of the women, they had significant past medical histories, and the diagnosis of the VTE was another factor that needed attention in their lives. And it was almost like adding to their shopping list of problems. And then having heavy menstrual bleeding on top of that was another problem that needed to be dealt with. So these were the 7 themes that emerged. And just to give you a kind of flavor of some of these, some of the quotes that we received. Sorry, I'm jumping a bit. So participant 2, I think when you read these side effects, you always think, oh, it won't be me. I was quite shocked for the first time. And this was a participant that had been counseled about the increased blood loss which may occur, but yeah, finding it quite shocking when it actually did happen when her first cycle came. The bleeding is always at the back of at the back of my head, like, when did I last change my tampon? Do I need to change my tampon? Am I bleeding through, or is it okay? Do I need to go to the toilet? Where can I go to the toilet? All those sorts of things. And it just shows the anxiety that can occur as a result of being worried about this. Participant 9 says, I was miserable and I couldn't leave the house, and I was nervous every time a period was going to come because I knew I wasn't going to have I was going to have the same issue. So the period study has been published, and I'm not trying to advertise, but if you did want to read a bit more about the findings, then they are available freely. So I'd direct you to those. So take-home messages, I guess, are that anticoagulation-induced heavy menstrual bleeding clearly impacts women. We need to do better in terms of information provision and support. And I'll come to that in a second. And I guess the question is, how do we support women better? Because they have typically a diagnosis of VTE, they need to start an anticoagulant. So what can we do to help minimize this problem and not wait for it to happen? So some strategies that can be adopted. Firstly, asking about periods. So when I was a young pharmacist, I guess as a shy pharmacist, when I would be talking to women about their periods and they might be heavier, I'd probably keep my eyes down and hope that I wouldn't get much of a response back. But actually, my practice has changed completely now, and I'm very happy to be talking about periods with patients where it's relevant. And we know from studies like the Menorrhagia study, Menorrhagia 1, conducted in Scotland over 20 years ago now, that there are some factors which can help us to identify women who are particularly at risk. And although Menorrhagia 1 wasn't done in an anticoagulated group of women, there's some common sense things that we can take away from it, which we can apply to our own practice. So women changing protection more often than hourly before they've started anticoagulants, if they're passing clots greater than an inch, if they have low hemoglobin or ferritin levels. The subjective reporting of very heavy periods by women is also a good predictor that, that they're having issues. So if women in clinic, if we talk to women in clinic and identify that they have some of these things before we start anticoagulants, if we keep our guard up, we may be able to tailor our anticoagulation therapy at that point, instead of starting something standard and then waiting for the problem to precipitate. So talking about periods would be one strategy. Of course, anticoagulant choice is an important factor. And certainly our experience at King's is that rivaroxaban does affect a significant number of women. And the experience we had from the period study is that lots of women are affected, but they just accept it and they just get on with things. And actually, we want to move away from that and try and say, actually, this isn't acceptable and there are things we can do to manage this. So one of the strategies we've employed locally is not to use rivaroxaban as a first-line agent in menstruating women, and we prioritize apixaban, where the incidence of heavy menstrual bleeding is less compared to rivaroxaban. It's not completely gone, but it's certainly less. And then we keep dabigatran up our sleeve as an option should we need to use it in a particular patient. One of the knee-jerk reactions which occurs when, especially when a VTE diagnosis is made, is to stop the combined oral contraceptive pill at the time of the diagnosis, because it's thought to be a provoking factor in that particular VTE event. But I guess it's important to remember that once you stop the combined oral contraceptive pill, you could be inducing withdrawal bleeding, which will only add to any heavy menstrual bleeding that a woman may go on to experience. And of course, the combined oral contraceptive pill isn't just used for contraception, but has its use in other indications as well. So experts now consider it absolutely fine to continue the combined oral contraceptive pill whilst a woman is anticoagulated with a VTE diagnosis. And then the decision about what to do with the COCP can be made in the fullness of time, depending on whether the anticoagulant is going to continue or not. And Martinelli's work, published in Blood in 2016, clearly shows that there's no problems in continuing the combined oral contraceptive pill whilst a woman is anticoagulated. the question of whether we can use tranexamic acid is always crops up, and there is a worry that tranexamic acid may worsen a VTE event. There's some good data from Denmark, which was published a few years ago, which followed women who were menstruating over a significant period of time and looked at the associations between the use of oral tranexamic acid and the risk of DVT-PE, or arterial thrombosis. Important to bear in mind in this study that they excluded women that had a history of VTE or were anticoagulated or had thrombophilia or cancer. They followed 2 million women for 13.8 million person years, and the adjusted incident rate ratios of VTE were 4 and 1.3 for arterial thrombosis. And the authors worked out that the numbers needed to harm on 5 days of oral tranexamic acid was 78,549. So even with that, a lot of people would consider that numbers needed to harm to be significantly high and actually acceptable to use tranexamic acid. And remember, these numbers are based on non-anticoagulated women. So of course you would expect that number to be significantly less when a patient is anticoagulated. Some recent work from Canada surveyed clinicians on their use of tranexamic acid specifically in this situation. And it suggests that around a third of prescribers don't prescribe tranexamic acid in this situation, with a significant number of them being worried or not being comfortable with tranexamic acid use. But there is also a significant number of people that do use tranexamic acid. And I guess when appropriate, we probably need to shift the dial so that tranexamic acid can be used in this particular setting, or is used when appropriate. And I know that our excellent registrars through the HemeStar network are looking to address this through a study, which would be great. At King's, after the period study was completed, one of the first things we did was to produce an information leaflet for women. So this was on top of the information that they would be receiving around anticoagulants. And this was just to help frame and provide specific information for women. And we then applied for the development of an animation through our hospital charity, which is now available. And depending on time and questions, we may share that to you at the end. But if not, it is in the lobby, in the conference lobby, if you want to see the animation. And the reason why we developed an animation was that there's quite a bit of research which shows that lots of patients don't absorb information through written information sheets, and having the visuals and watching through a short animation can help to frame information quite well for lots of patients. So we have this animation available, and we're happy to share that with any clinics should you see it fit and useful in your clinic setting. And then our practice at King's is, as I said, we've moved away from using rivaroxaban in menstruating women. We use apixaban in our DVT outpatient services, and wherever possible for our inpatients when we're doing our ward rounds. Our DVT service also, when the diagnosis is made, our DVT nurses ask the patient to complete a screening tour, and it's just a series of questions taken from Menorrhagia 1 and Samuel Sambano's work, where we just, it helps to frame the issue for women without scaring them. And it also helps us to decide which women we need to keep our guard up with. So they complete this in clinic, and then at least we have a baseline before the anticoagulant is started as well. And I have to say, since changing from rivaroxaban to apixaban, and there's been a big shift in the number of women that report problems, which has been a good thing. So just to finish the talk, just some acknowledgements. So for the period study, Dr. Roberts and Professor Aria, gynecologists, so Uju, Gemma and Jackie, and then the qualitative work was led by Dr. Amelie Ding and Umber Sheikh, and of course the women of Southeast London who took part in the study. And then for the animation was developed by my colleagues Emma G, Dr. Czaprinska and Rosalind Byrne, and the King's College Hospital charity who funded us to do the animation. So that's the end of the talk. So thank you. Just gonna stop sharing.
Thank you, Jig. That was really interesting. Would you like to, we've got a little bit of time, so would you like to show the animation?
Yes, have you, yes, are you able to? Yes.
Just one second. So actually in the hall of the conference, under the library and in the videos, you can see the animation there. And I know it's available either through Jig or Thrombosis UK, so that you can put it and make it available in your own clinic. So I'll just run it now.
Anticoagulants work by preventing clots from forming in your bloodstream, but sometimes they can affect your periods too by making them heavier or longer. So, what are the typical signs of heavy periods? If you have to change your sanitary products every 2 hours or less, if you experience flooding or blood leaking through your clothes or on your bedding, if you have continuous bleeding that lasts a lot longer than your usual period, if you pass clots bigger than a 2p coin, or if the blood flow keeps you from getting out of the house or going to work. If you have any of these signs, speak to your anticoagulation clinic or GP. What can you do to help yourself? You should let your anticoagulation clinic or your GP know if you already have heavy periods or a condition known to affect periods. This includes fibroids or adenomyosis. If you take contraception, don't stop taking it before discussing with your anticoagulation clinic or GP first. If you begin to feel dizzy or faint, become short of breath, or if the bleeding is really worrying you, you should seek medical help. How might the anticoagulation clinic or the GP be able to help you? You may need a blood test to check your blood counts and iron levels. You might be given iron supplements. They may also change your anticoagulant or add an extra tablet to help reduce your heavy bleeding. In some cases, taking hormones such as progesterone or having a coil fitted may help your symptoms. These options may be discussed with you. It is not uncommon for women prescribed anticoagulants to develop problematic heavy periods. If you are affected, please don't suffer in silence. Help is available through your anticoagulation clinic or your GP.
Thank you. And as I said, that's available to use in their own clinics and centres, isn't it? As well as to view within the conference platform as well. There are a few questions have come in. I have to say, Thrombosis UK has been really impressed with this video because it's an issue that we often hear from individuals, and thank you to yourself and your team and King's for allowing it to be added to the app as well, so another way to access it. But some of the questions coming in from the audience is, how does the rate of menstrual bleeding, or does it, change with apixaban at 2.5 milligrams BD versus the 5 milligrams BD dosage? Is there a change in that? Is that something to be considered?
Yes, so you would anticipate the bleeding to be less with the lower intensity of anticoagulants. And certainly in the early days, some of our practice in clinic was to reduce the intensity of anticoagulation when a cycle starts. Um, it's it's perhaps a consideration, but also I would say that it's to be considered with everything else that can be done to help manage the problem for the woman. So I'm less inclined, particularly during the acute phase of treatment for VTE, to do that. But perhaps longer term, if someone's on secondary prevention of VTE, that is a strategy that could be employed. Our experience also suggests that using enoxaparin during the cycle can be very helpful for a lot of women. It comes with the disadvantages of having to inject, but certainly for some of our more problematic cases, that's been a good go-to in in those situations. And I should say that there is a group of women that do need gynecological input. But what we're trying to do here is to try and manage problems from across, to try and prevent the problem in the majority of women, so that the ones that the gynecological team need to see, they do see, and we can try and manage for the majority of women.
Thank you. You'd gone through a number of strategies, such as considering an alternative anticoagulation, and also the importance of having that conversation from the beginning. But somebody's asked, had it been considered reducing the dose of anticoagulant for the first few days of heavy menstruation? And there would be other issues with that, but what were your thoughts or experience on that?
Yeah, I think again in the early days that perhaps was something that we considered, but there is some evidence that suggests that if we take our foot off the pedal for during an acute VTE event, that can be problematic. So I think longer term, that certainly can be a strategy that can be discussed with an individual patient, but I'd be less keen, especially in the first month, to be doing that, and trying some of the other things are probably better to do.
Such a helpful study, but one of the things you highlight is that actually the early communication, even before the prescribing, is as important as all the other strategies along. And in your own centre, have you found that you've needed to, or have you changed any training of staff, both of awareness of this, but also how they communicate? You explained yourself, as a young pharmacist to now, but how they communicate with patients to try to open up this subject and therefore protect them or prepare them for what might occur.
Yeah, that's a good question. Yeah, we haven't done any specific training with our team members. I think by doing the study, and with many of our team members being involved in the study, I think it just naturally led to them being more comfortable talking about this when they were having those clinical conversations. So I'll talk about myself as opposed to someone else, because that's the experience I have, but I certainly feel much more comfortable now just talking about periods with women, in this context. And I think that to me just seems like a good place to be, from that. I think we all need to be in that position. And so although there no particular training, I think just by doing the study has made me more comfortable talking about this. And yeah, it's I think hopefully the information sources we have, that they frame the issue for women, and the feedback we've had is that it does sink in without scaring them, because what we don't want to do is alarm them even before they've started anticoagulants. But I think hopefully the way it's framed is kind of makes them aware and gives them permission that they shouldn't just suffer in silence. They can contact us and we can help manage this with them.
Yeah, I think that's really important. But I think also, I think in this situation, it can be also very scary if you suddenly have an unusually heavy menstruation and you weren't expecting it. So the other sort of flip side of that is the fear that can come then, and then opening up that conversation. So by doing it at the start, it's so important. Obviously, a part of this is important to bring into primary care as well, because that's where patients may also be presenting to discuss or even to have anticoagulation. Have you had any plans or progress in presenting and sharing this wider to the primary care community to make sure they're aware of it as well and update them?
Yeah, no, that's a good suggestion. We haven't, just because we've been trying to sort ourselves out first. But I think that's a really, really good suggestion because, as you say, a lot of patients will present to their GP first, and actually we can do a good job in kind of educating our GPs as well of what strategies might be helpful when they're seeing patients. It's a good suggestion.
And then finally, I'm aware that King's, as you showed briefly, have a couple of really good resources for this. There's a fact sheet as well. If anybody is here and they would like to borrow this or use it or anything, are they able to, and how can they contact to liaise with you? Because certainly we've looked at the fact sheet and it's really helpful.
Yeah, well, thank you, Joe. So yes, they are available. So you can just email me. So it's jignesh.patel@nhs.net. And the video is available through YouTube, but I know some trusts have a firewall on YouTube. So I have the original file. So if your trust is affected by the firewall to YouTube, then I'm happy to provide you with the video that you can just ask your IT department to upload to your intranet, and then it just bypasses YouTube. So yes, happy to share it. We want the resource to be used as widely as possible if you see it useful in your clinic setting.
Brilliant, thank you. So it can be put into a clinical setting to be used there with patients. And I don't mean to plug this, but with your permission, we've got it on the patient app as well, so that is another option to either signpost to or to share in that conversation when they're in clinic with you. We're out of time, I believe. I'm just going to double check. There is one more question, sorry. So for a young woman with atrial fibrillation with normal renal function who is, I struggle saying this, with menorrhagia, would you prefer a Pixaban 5 milligrams BD or rivaroxaban 15 milligrams OD?
So with a normal renal function, they typically would have rivaroxaban 20 milligrams once a day, but I would certainly use the Pixaban. I don't use rivaroxaban in this age group now because for this particular reason. Yeah, I think our experience with the Pixaban is good, and then I think dabigatran is a suitable option to try if you run into problems with the direct 10A inhibitors.
And obviously, on the whole, it's mostly for VTE because often
Yes.
AF is in an older generation. So
yeah,
we're running out of time, but thank you so much, Dig. Really interesting and such valuable work that I know will help so many. Thank you very much.
no, thank you. Thank you, Joe.
Bye-bye.
Bye.